Friends and colleagues, thank you for joining us for another session of the Dublin's Operative Grand Rounds. Today we have two distinguished speakers, Dr. Giuseppe Lanzino from Mayo Clinic in Rochester, Minnesota, and Dr. Jacques Morcos from University of Miami. They'll be talking to us about the emerging technology of flow diversion for cerebral aneurysms. They will give each one talk, first Dr. Lanzino, and then at the end we'll have about 10 to 15 minutes of discussions regarding controversial issues. Giuseppe and Jacques, thank you for joining us, and Giuseppe, please take it away.
Thank you, Aaron, and thank you to the AANS for this opportunity. Flow diversion has been utilized for the treatment of intracranial aneurysms now for 5 years. And I think it's important we should be able by now to put this in perspective. So what I'll try to do, I will try to define what is, in my view, the role of flow diversion for intracranial aneurysms based on some of the data available as well as on personal experience. And then also briefly touch upon some of the most important complications of this technology. These are my disclosures, and just to briefly elaborate on the concept of flow diversion, the idea is that if we are able to place a device which has a high metal ratio across the neck of the aneurysm, we are able to modify flow dynamics so that flow is redirected into the parent artery away from the aneurysm. And this in turn will promote some stasis and eventually progressive thrombosis of the aneurysm over time. And I think that we can say that flow diversion is the treatment of choice for complex proximal internal carotid artery aneurysm, which is also the type of aneurysm for which this technology has been approved by the FDA. So the concept actually works very well in these cases. This is a patient that was treated because of refractory retroorbital pain for several months. We thought this could have been related to this fusiform cavernous sinus aneurysm. You can see here with the placement of 3 telescoping devices, the reconstruction of the profile of the siphon and the classic delayed intra-aneurysmal stasis that often you see, and this immediately after placement of the device, disruption of flow, and again, a delayed stasis into the more sacral portion of the aneurysm. And this is the 6-month follow-up, and you can see on the AP really the beautiful reconstruction of the profile of the internal carotid artery. This is, I think, it's another ideal case, a middle-aged lady with an incidental finding of this very large carotid ophthalmic artery aneurysm. This was also treated with flow diversion, and this is a 6-month follow-up in this patient. Now, I think also flow, so those are definitely what in my view are ideal cases for this type of technology. It has been nice for me to see over the years how the animal studies correlated with the clinical situation. This is from studies in rabbit that were done by Dave Kelms here at the Mayo Clinic, showing that basically after replacement of flow diverter in the rabbit aneurysm model, you have formation of a clot, and eventually the clot acts like a scar, so it retracts, and the aneurysm actually shrinks. And again, this is a nice correlation with the clinical situation. Patient with the intermittent ophthalmoparesis from a giant cavernous sinus aneurysm, treated again with flow diversion, 6 months follow-up. There is still very small residual filling of the aneurysm. And more importantly, here is the pre-treatment, and you can see there was displacement of the pituitary stalk, and at 6 months there has been a shrinkage of the aneurysm with the improvement of the mass effect. Of course, this is a phenomenon of shrinkage of the aneurysm that we see as long as the aneurysm is completely obliterated